Good morning. So we're going to change a little bit. For the next 20 minutes, Dr. Bittner and I are actually going to debate. We're going to try and convince you that our way is the right way. First, I want to ask a general question. How many people here do laparoscopic ventral hernia repairs with show of hands? Keep your hands up. That's a lot of people. Now, keep them up. How many people actually close your defects? That's a good proportion of you. Okay, I can go home. Thank you. So for those of you who didn't have your hands up, I'm going to try and convince you to do so. How do I? Just the green button. Thanks. I have no disclosures. So I'm not here to debate what's a right approach to a ventral hernia repair. Lap IPOM is certainly one, but we have a whole slew of other procedures in our ventral hernia armamentarium that we can use for different patients. And there's certainly, the slide doesn't come up. Okay. There's certainly not a one-size-fits-all philosophy when it comes to ventral hernia repair. We have a lot of different patients with a lot of different things that are called ventral hernias. Clearly, all these patients shown here have different operations in store, and they're not the same problem, they're not the same disease, and they shouldn't be treated the same. But what I want to discuss is for those that in your practice you think are appropriate for a lap IPOM or standard lap ventral hernia repair, what should your technique be in 2016? I would argue that it doesn't need to be the same technique we've been using since 1993. So Dr. Bittner, who's going to follow me, is going to for sure throw this article in my face, which is the Sentinel article for laparoscopic ventral hernia repair. It was published in Annals of Surgery in 2003. It was the largest series at the time that used the unified technique to do laparoscopic ventral hernia repairs. And they showed in an area where the open recurrence rates were between 12 and 52%, that the laparoscopic hernia has a much lower recurrence rate of 4.7%, and it was certainly acceptable and reproducible. So how did they use their techniques, or how did they come up with their technique to do the laparoscopic ventral hernia at that time? They modified the open reef stope approach and converted it to a laparoscopic approach. And those steps are as follows. Essentially, you excise or imbricate the hernia sac. You place your mesh posteriorly. In an open, they put a retrorectus. In a laparoscopic, they revise it to an intraperitoneal position. You broadly overlap the mesh and use transfascial suture fixations. But in the open approach, as those of you who do it, you know, at the end of the procedure, you actually close the defect, which in the laparoscopic approach we don't do traditionally. So why didn't they actually add that fourth step to their laparoscopic IPOM? I would argue that at that time, when the study started in 1993, the instrumentation and the ergonomics of a laparoscopic intracorporeal fascial closure was too difficult to literally perform routinely and teach it reproducibly. But is that still true in 2016? I remember sitting in this auditorium, or something similar to this, in SAGES of 2004, and the question wasn't at all whether or not we should close a defect. The questions at the time were, how large a defect can we actually bridge? So no one even thought that we should or could close defects at the time. So now what are the advantages of a laparoscopic IPOM? No question, over the last 23 years, we've proven that it's faster hospital discharges, faster recovery, faster return to work, much lower wound and mesh complication rates, lower hernia recurrence rates, and reasonable cosmesis for those of us who care about that. But don't forget that an IPOM has many, many pitfalls. Those of us who do them routinely know there's a high seroma rate and skin bulging rate associated with it that bothers our patients a lot cosmetically. There's weakness over the bridge gap, and the risk of mesh eventration is real. And certainly for the young patient, the lack of core support and functional stability is also a real problem. Lastly, the intraperitoneal bowel adhesions to the intraperitoneal mesh placement, it can also be a real problem. Now, is a traditional lap IPOM a good repair? Absolutely, I'm not here to debate that. But can it be modified to overcome some of those pitfalls that I presented? I think that's true in 2016. And do we have the skills and tools to do so? Yes. So for a minute, I want to spend just a few seconds on the last problem there. And I'd just like to state that there's a lot of R&D dollars spent to reduce that intraperitoneal bowel adhesion to the mesh problem over the past few years. And now there are innovative surgeons who are trying to figure out how to actually put the mesh laparoscopically preperitoneally to avoid that problem completely. So we're constantly trying to modify our technique to address these problems. Now, how do we address the top four? Well, you just have to close the defect. It's not rocket science. Now, what would closing the defect actually accomplish? So I have no proof for this, but it's logical. It provides a better uniform scaffolding for the mesh ingrowth to happen, and hypothetically, you'll get a stronger repair. It certainly reduces the risk of mesh eventration if you actually don't have a hole. It eliminates the inevitable unsightly bulge and seroma that I have to deal with in the office every other day. And it better approximates the physiologic abdominal wall tensile core strength and functional stability that a lot of younger patients want. Sorry. So this is not a novel concept. I want to give credit to Dr. Franklin. I don't know if he's in the audience or not, but right around the same time where the Annals of Surgery paper came out, Dr. Franklin was writing his own paper of 384 patients during the same kind of time period between 91 and 2002 that he did laparoscopic ventral hernia repairs. And the way his technique differed from the other four was he actually closed his defect. He closed them with a shoelace percutaneous technique, but nonetheless closed the defects. And he proved that over his cohort of patients, the recurrence rate over almost 6-year period was 2.9%, which is pretty good. So this is not a new topic, but we're just now starting to talk about it. So the technique, I'm just not going to get into it. The only thing I'm going to add is the way most people close their defect. Either they use a running braided suture at this point in time, or still do the figure of 8 shoelace percutaneous technique. So what factors determine the success of a durable defect closure? I think there's multiple factors. The suture type, the tension of your repair, and your technique actually matters. The abdominal wall compliance and the musculature matters. Closing a defect in an 80-year-old wheelchair-bound patient is very different than a 21-year-old bodybuilder. The size, type, and location of the defect matters, and defects around bony structures are much harder to close. And the size, type, and strength of the mesh that you use for your repair also determines the durability of your repair. Now, what have been the historical objections to defect closure? I'm sure Dr. Bittner is going to bring these up. Well, the one that most people talk about, sorry, there's a video that's supposed to play here. How do you get here? I'm clicking. Oh, there we go. The one objection that most people have is that it's cumbersome. It historically has been cumbersome, and as someone who does this laparoscopically, I will tell you, it's no easy feat to sew backwards, on your head down, backhand. It's definitely difficult. And the other argument that they will use that you're converting a tension-free repair back to a tension repair. And this can probably carry increased recurrence and failure rate. So I will say we're trying to overcome the cumbersome argument. With the advent of the braided sutures, no question this is an easier suture to run than a standard regular monofilament suture. And with the robotic platform, many of my colleagues have been able to sit and overcome the ergonomics of operating upside down on your head. And I think that, no question, makes it easier to do and more reproducible for the masses. Now, are we truly converting back to a tension repair? No question that a tension repair is a step backwards, and none of us want that. But I would argue that an abdominal wall is not a rigid structure. It's got plenty of laxity and compliance. And actually, if you're worried that your defect is too wide, that closing it, you're actually causing tension, then that's probably the same defect you really shouldn't be bridging. So where's the data? Everyone asks for data. There is no level 1 evidence for this. The closest we get are plenty of small and medium-sized chart review cohort studies, as Dr. Franklin's that I mentioned, and all of them suggest lower seroma rates and potentially lower recurrence rates. Most recently, in February of this year, this was the largest series I found, which is 1,300 patients laparoscopically. It's out of Belgium, closed with a shoestring technique of the defect closure, and with a very long follow-up of, I think it was over 6.5 years, they found recurrence rates of 4.72%, with no different in complication rates. So, who do I close their defects? In my practice, both patient and the hernia have to qualify for a lap IPOM. Again, this is not one size fits all. Not everyone gets this operation. In my hands, the defect has to be less than 10 to 15 centimeters or greater than 1 to 2 centimeters. There's no point wasting your time in a small little umbilical hernia. This varies with abdominal wall compliance. Obviously, the older the patient, the more compliant their abdominal wall. Generally, I don't do this in the obese patients. I do them in the patients I predict larger post-op seroma and bulge. I don't waste my time in Swiss cheese defects. And I do them mostly in the younger patients who actually care about their functional stability. So in conclusion, is a lap IPOM after 23 years still an acceptable procedure? Absolutely. Should we modify it? Yes, we should. And just like I polled you, we polled our esteemed colleagues on IHC, and an overwhelming 83% agree with me that we should close these defects. And just so you know, my colleague that's going to come up also always closes his defect. Thank you.